Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 142. It's an absolutely gorgeous spring morning in New York City and in Manhattan, and we are delighted to have you join us this morning. I'm also happy to introduce our guest today, Dr. Jaswinder Singh, who's the Director of the ARCH Consortium and the Director of Interventional Cardiology at the Washington University School of Medicine and at the Barnes Jewish Hospital in St. Louis, Missouri. Jaswinder, good morning, and thank you so much for joining us.
Good morning. Good morning. Thank you. Thank you for having me.
And congratulations on your recently concluded ARCH Symposium. I heard it was a fantastic success.
Oh, yeah. We really were blessed to have such amazing faculty and such amazing support from industry. We had close to 1,000 people signed in, virtual and in person. So it was a challenge, but it was amazing. So thank you very much.
Exactly as the subtitle said, the hybrid approach to it and getting it exactly right. Congratulations again. We have an exciting case today. Let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are there, and we'll take you through the details and the plans of the case and continue to benefit from our expert guest today who will lean on the case with his expertise. Samin, good morning. Good morning, Anu.
Good morning.
All right, good morning and welcome, Jaswinder. Of course, Samir, this is the 142 episode, all uninterrupted. And thanks for you, actually, Jaswinder, making the out of the box now the live meeting, people being there and giving us opportunity. And I'm glad you had a great experience. And this is where the field has to go. COVID should be bye-bye. We go with our life. And this complex case will need a lot of help. And welcome.
Well, thank you, Samin. Thank you, Anu. Thank you for all the good work, and thank you for all your support also.
Okay, now can we go to the slides, please? And then we'll just show this case quickly. These are our supporters. The usual disclosure, nothing new. And then, of course, we have Jaswinder Singh today as a guest faculty, as Dr. Mehta just mentioned. Now, this is, as mentioned, episode 142, 43-year-old male with end-stage renal disease on hemodialysis. He actually presented with new onset class 4 angina and small non-STEMI in February end. He has controlled hypertension, initial requiring diabetes, already has CVA and positive lupus anticoagulant for which he has been on warfarin. No CAD or cardiac issues before that. Then very active otherwise, got the PCI at that time, and then currently just have a mild symptoms and of course a good medical therapy, but one of them being uncontrolled hypertension. And he has calcific 2-vessel CAD, one of them which has been taken care, and this is what we are going to show. The left system which you did yesterday, last week. The LV actually looks a little down than before. It was 55 inferior wall, looks more hypo now. Moderate diffuse disease of various vessels, particularly OM definitely has progressed. This is about 2.5 months later. And LAD had a stent with a small subtotal, but LAD stent is good. Now let's talk about the right. Look at the collateral of the right coronary now. Mega right coronary, very distal branches. And this is where we are now. This lesion was about 90+% at that time. And now it has become 99%. And look at the calcium, which is with the age and more importantly, patient with the renal failure. That's what we have. Extensive calcium, severe calcium, and we're ready to embark on it. And whole goal was that once you go to the distal branches, those AV continuation, these are also additional 90+% lesion. And we felt that after we take care of the mid RCA, we use the 7 French Godzilla, and because it will be very tough to advance the rotablation even with the extra support wire or a small burr. And so that will be our goal. But first we need to take care of now is the new mid RCA. Anu, you agree with that, right? This is a much change than last time.
Yeah.
Samin and Anu, excellent, I think, selection of a case, very complex, tortuous, super dominant right coronary artery, which has become subtotal. Jaswinder, what would be your approach here? How would this be approached in St. Louis?
Well, I can see your guide catheter. I think first thing is, obviously very, very calcified artery. I think it's probably deep and superficial calcium. So you need a pretty aggressive guide here. So I think I can see they're probably putting an AL 0.75 in there. So that's a big start. So you already have a pacemaker in place. So I think atherectomy is planned. And without atherectomy, I don't think you can really do this lesion. So I think those are the two things that I would start in the beginning. Absolutely.
This catheter is already
and
kinked.
and
get
a
it going.
pacemaker. You could probably give aminophylline if you
Tell
wanted
them
to
to
do
get
something.
a mark. This doesn't even rotate.
You want to do atherectomy. So I
Get
think
the mark guide.
that's number one, and number two would be
Mark guide.
firing would be difficult primarily. So obviously microcatheter, your workhorse wire, or even a slimy wire to get through, and then change over to a rota. And I would do a rota extra support in here because of that angle, and try to get more purchase. And after vasodilators, after you get vasodilators and you improve the subtotal lesion, then distally, whatever you can do, you'll have to just figure out after the artery actually becomes much bigger because it's subtotally occluded. You have widespread collaterals from the other side.
All excellent recommendations. I'm sure both Samin and Anu would concur with those. What about, would you have any other alternative in mind besides rotablator as a atherectomy strategy, or just because of the level of calcification, that is obviously the right choice?
0.75.
Well, I really think it's depending on
0.75.
comfort level. Is I think Samin and Anu are world's expert in rotational atherectomy, so I think the education that's going to show us is amazing. But orbital here, I do a decent amount of orbital. Orbital will work here. There's no two ways about them. They have a very good wire that's flex tip. You can actually wire with that, and then do orbital. The other would be,
The question then we just go with the Lima.
5 balloon angioplasty, make room for shock wave that could potentially work. But I'll tell you, the proximal right is tortuous. See, they're having problem getting the guide in. So trying to get balloons and opening it up and doing all these things is going to be very challenging. So subtotally occluded lesions like this, I think the algorithm would be atherectomy, and rotational is probably the way to go, but orbital can work here. Absolutely.
Yeah, good.
So what has been, Jaswinder, your experience with the IVL already? Have you done a few cases, more than a few cases?
Good.
Yes, I did a lot of I used peripheral.
Good.
So I do a little bit peripheral. So I did peripheral, but I did the peripheral catheter 40 millimeter in coronary. So I've done a decent amount, and we've had it for the last 2 weeks. And I showed a couple of cases during ARCH, and we have had pretty decent experience with it. Absolutely.
So what kind of lesions are you selecting the lithotripsy for?
I need to go disengage.
Well, it's several scenarios. I mean, if it's a angulated lesion and it's not that tight, and if it's larger, it actually yields the lesion much, much better. I mean, the other scenario where it's really not studied for yet is underexpanded stents, where you take it down there and the stents are hourglass with calcium. But this actually tends to, because of the waveform that it creates, the shock wave that it creates, it breaks a lot of calcium behind it. So that has a potential use of it. We use laser now, and sometimes we use laser with an off-label with contrast and stuff. So, but I think that works for those scenarios. So larger vessels, because it affects deep and superficial calcium, it allows you to have good luminal gain. But subtotal lesions like this, I think, is going to be harder for it to perform. So I think the more we use it, the more we will know where it performs.
Excellent. Wonderful. Anu, what wire do you have? Is it a run
This is a fielder and a fine cross. Yeah.
Okay. Yeah.
And we actually, you see it, there is no lot of dampening earlier because there is no side holes in this 7 French AL 0.75. You needed, as mentioned, you need a little guide support. Good. Rota extra support wire 1.5 or 1.75.
175, I think.
Okay. So we can take 1.75, yeah.
Anu, very good combination here as the initial fine cross and fielder. It's done the job so far.
Yep.
But exactly as Dr. Singh pointed out, there are going to be issues and challenges with the guiding catheter support, the subtotal,
Can you give
very
some
large
dice
vessel
so I know
and the
which vessel, how the
calcification.
vessel is?
You'll see we do cases very, very similar. This is great. I mean, this is the
That's fine.
very
Do it
educated,
right now.
really.
That's okay.
Guide support, microcatheter, your filter wire, and then your rotor wire. Your bias is going to be tough. So are you guys using rotor extra support? Or
Yeah, definitely. This is,
have you used the new rotor wire?
yeah, new rota wire we used. I mean, I found that more flimsy, the new rota. So rota direct. What was the name of the rota?
Yeah, rotor direct.
Yeah.
Exactly like the Viper Flex.
Yeah.
I
so-
think when you're
Okay,
doing
yeah.
atherectomy, you don't want, something with like a glide wire.
Rotor drive, rotor wire drive. So key is that I think you're still trying to use it. Yeah. So I would think will be probably good in many of those tortuous situation. Had little definitely one better one-to-one torque. But I have few cases when we tried, we tried like 10, 12 of them. Even mid LED, the rotor drive just didn't take it through the moderate tortuosity. I changed it to rota extra, regular rota, not even extra support, rota floppy, and then burr vent.
Balloon.
Yeah, well, that's an
3.5.
amazing point because I
3.5,
really,
20.
I'll tell you, for me, about 80% of my cases are rotor extra support still.
Oh. Rare
So-
situations we use extra support.
Yeah, we
Yeah,
actually little
we
other
are-
way
we are
around.
more.
We are like 95% floppy and 5% like this kind of case, or 10% osteal lesions
Distal.
and distal
Very
lesions.
distal,
Yeah.
yeah.
Like this case will be a case for extra support. So we are a little different, but what is doing?
It's
So
all
Jaswinder,
how
what would
comfortable
be
you are.
your choice of how would you size the rotor blade?
I would not use 125 here, number one, because I'll tell you, it'll jump and it's angulated. So, you have to be very careful. It can stall. I think 1.5 is probably in this case, I'll start with a 1.5 in here.
Anu, is that your strategy? Is that the plan?
Yes.
We went 175.
Just-
Remember, we have always taught that if your microcatheter traverses the lesion, then you don't need 125. And so here I think the question is a large vessel, and where looks the guide has we have a good guide support with the extra support. Even we don't have a good guide support, as long as we have extra support wire and it's a short lesion, we should be able to do 175 bar.
But yeah,
Since the
using
vessel
a-
is
You
very
would
large.
you would have no objection, Anu, though, if one was trying out with the 1.5 starting.
No,
when
then
it's-
will be 2 bar.
Yeah.
Then you have to think of 2 bar. That's why we are going with 175, hoping later on maybe we can just do with high pressure balloon. If not, then we can use a flex tone.
Okay.
I mean Wolverine.
And actually the original plan was use 2 bar, maybe 1.5 and then 2.0. But now knowing that what is going on distal vessel, let's open the mid with the 1.75.
Got it.
And yeah, so before we go on, let's complete this today's presentation. Go back to slides, please. And we are ready with the 1.75. As you know, this LED was taken care, put a Xience Sierra, and then used to be an aspirin that was changed to clopidogrel. Always 2 therapies, never DAPT plus anticoagulation. So this patient has been on warfarin and clopidogrel, and now today we plan to do the severely calcified and tortuous RCA using rotablation and guide extension catheter for distal delivery of the device. And imaging for stent optimization that we may decide in the end. As far as the appropriateness is concerned, this case will be non-proximal LED or left dominant system, but appropriate because of 2 drugs. And so, although we don't have any imaging, but this was a non-STEMI and is still on 2 drugs and so. So we are ready here with a 1.75 bar. Let's go to the procedure now. Yeah. Right now we are going directly. Yeah. Go.
Yeah, the good point was that Anu made is it's a short lesion. If it was a long lesion, you use a large bay, you run the risk of reflow, and you'll see the technique. And the technique is important, and it's a shorter lesion, so you could go with a larger burr here. Absolutely.
And this one actually the slow flow to begin with already. So we had to be just very careful, keeping the blood pressure up or all areas that all points, avoid hypotension and if necessary using the vasodilators and increasing the vasopressor to increase the pressure. Continue show the hemodynamic on one side, the systolic above 100, give a neo.
So just I think another point where we are going to show. So this is the anterior take of RCA. So the guide is just at the, proximal RCA. So you'll see that now if I try to advance the burr,
Yep.
Guide will come out. See that? So the same thing can happen when you have a shepherd's crook RCA also, or when you're doing ostial RCA. In that situation, the best thing is you leave it in the guide as far as the burr will go, and then do your 3 steps in the guide itself. Normally we teach you go to the proximal vessel, but here do your 3 steps where you're moving the knob backward forward. Here your Teflon sheath that you're moving backward forward, and then finally do the dyna taps.
Yeah, and advance
See,
on the
it
guide.
did not happen.
Yeah.
So now we will start burring, or you want to go dyna inside. One of the two you could do. I think we'll go dyna.
Yep.
Yeah, since the lesion is in the mid RCA, we don't need to lose our rota length. So what we'll do is you go dyna. So this is a very important step where people keep asking. So you do a brake release. Since this wire that is being held by the brake is released, he's on dyna, and I will manually advance now.
Yeah, go.
Press. Good.
Which is 60,000 RPM.
Yes.
Less trauma.
Okay. Now
from the
you see that
proximal.
after this, the burr is not moving. It's behaving like it's stalling. That's okay. It could be also many times you have to remember the stiff wire can still cause wire bias. So let me try to start burring at this level.
And you have
Now
to
see
bring
the
guide
guide
a
is
little bit in. Yeah.
it's hitting the.
You can see the noise. I mean, the noise came.
Out.
It's
Little
can
bit
stall. I
behind
think they're
that.
going to straighten it back now.
Yeah.
So
I think it's a lot of
audio
wire bias.
feedback.
Let me just take a picture.
Samin,
So
a
the
quick-
wire, you see that the wire is biased towards the outer wall.
Yeah.
Maybe it's going against us, the stiff wire.
Stiff wire, that always the problem with the stiff. Does a little more wire bias, but we'll see. So if we need to downgrade, we'll go with the floppy wire and we'll go with the 1.5 bar. Those are the 2 things we are going to do.
No, I don't want to go.
yeah, the speed. No.
Yeah,
I
not
think the
even that
speed
you
is
can.
not good.
Yeah,
Yeah.
yeah.
Exactly
going to come
what
out.
was Dr. Singh's observation. And Samin, a question has
Floppy
come
wire,
here.
yeah.
Why not augment the flow by balloon inflating in the mid portion?
Oh no, but then your whole purpose of your atherectomy is defeated.
Yeah.
Yeah. So
Plus, you can cause
create-
bad dissections and it can stall. if
and
you
then
put it
create a
on-
little bit of dissection channels.
Change to floppy.
Yeah, rotor floppy and 1.5 bar. We do both.
No, don't change. Let's change one thing.
Okay.
No 2 changes.
Okay.
Let's change
So
to
just
rotor
just
floppy.
changing-
wire.
point of view, yeah.
Just downsizing the burr.
No, we're
other
changing
way
the
around.
floppy wire.
There's a lot of
Okay.
wire bias, so we'll
So
change
changing
to
the wire
floppy
and
wire.
staying with the 175. Okay.
Right, for the time being. So we wanted to make one change at a time.
Got
And
it.
just I think this is all learning and teaching for everybody.
Makes
So if you
complete
see-
sense. Stepwise approach. Let's.
So if you see here, there's a total wire bias. The wire is on the outer wall of the vessel. On the cine, you see that. So we will go with the floppy wire, thinking now, hoping that that wire bias will be gone and will be in the center of the vessel. And we'll just try 175 bar. If that does not work, then we change to
Then question is, do go to change to 1.5 or 1.25? If you really have to downgrade.
125, I
1.5.
would do.
Nothing. Okay. 1.5. All right. Go.
But I will tell you, Anu, that was so educational, the audio feedback, and then you stopped. I mean, the bias, and look at the bias before you burr. I mean, these are the things really are basic 101, in people who are experts in rotational atherectomy. So that was a very, very educational. I think we'll change the wire bias and see what happens. I mean, this is very instructional.
Good. Okay. Leave it there.
no, wire is not going to go all the way down.
Yeah.
No, the floppy wire.
Yeah. Ready. Okay. We're taking it out.
Okay, good. Get me the floppy ready. I never
The guide is
expected that
sitting
kind
good
of a
now.
wire bias.
Yeah.
In this vessel.
And particularly wire bias in a calcific
Large
vessel.
No, large.
Large and more important, calcific. Remember, the wire bias occurs in the pliable vessel. But in calcific also sometimes could occur, and this is the classical case.
The commonest
But this
vessel where we see wire bias is the circumflex,
Yeah.
proximal circ. or may ostial, proxial AD and takes at an angle. Yeah,
Good.
let's see now.
Yeah, this is a dialysis patient, so it's not only superficial, but it's also deep. So this artery is as stiff as they come, unfortunately.
Okay, let's see. Hopefully this will behave.
And question is, before we go with the burr, you want to just take a little picture, see where we are, and not created any extra damage?
No, I don't think we did anything, SS.
Okay.
We just tried.
Yeah. Well, remember, these device, rota can go into the wall of the vessel, create a gutter.
Okay. No, you take a picture, but I never. Essentially, what we are trying to say is you have to know the limitations. So, the way the sound, it's not just tactile; it's also auditory feeling when you're doing rota. When the drop of 5,000 RPM, your ears should be used to that sound. So I think, like Jaswinder mentioned, he kept saying the sound is not good. It's exactly, I think, what rotational atherectomy operators should be used to. The tactile was not good. That's why I said, let's stop now. And you saw the RPM was dropping. So that's why we did not advance. But what Dr. Sharma is saying is take a picture and see that still we have not caused a gutter.
Yeah, let's see. Little die.
Anu, a little bolus further of Neo before you make another.
Good.
I think we are good.
Yeah, no, Neo definitely. That our the will is our nurse here, so they all know it.
We don't tell the
they know it.
Well trained.
Well trained. They have the neosynephrine boluses, and which we have published quite a bit. That is 1 milligram per ml, and then goes to 10. And then it's dilute further, make it 0.1. So 100 to 200, put it there. Again, check the speed. 100 to 200 micromolar, 0.1 to 0.2 milligram IV, which increase the blood pressure for 3 to 5 minutes, like happened earlier, and now went down. Okay, let's go. Test ready. We're going to test it now.
Okay, we're going now.
Yep. So question was that if you have a choice, I think with changing to floppy wire and 1.5 bar, both were appropriate, but we were just wanted to even learn ourselves that whether it makes a difference only the floppy or so. So we are here with the 1.75 bar and and the floppy wire.
I think this is going to be the most instructive educational point of this session today.
Go.
There we made the progress. Excellent demonstration. Exactly the point you mentioned, eliminating the wire bias. I mean, this was not making any advancement before. Exactly the same burr. Wonderful technique, Anu.
And hemodynamics, you see the blood pressure systolic more than 100.
Right.
Come out, right?
Do a little more polishing.
Yeah.
And I'll change the wire direction a little bit.
Yeah, another run.
We're good. Don't change anything. See now.
And it pays a little bit, but the hemodynamics
vertical. There's the disease there also. Yeah, good. Okay. The entire area polishing. And remember the patient needing a pacemaker at that time, which is okay.
Right.
Pace. All right.
You want to do distal? I don't think.
No,
Hold on.
Distal not with this. Will be small. There the branch.
No, that's
just take a picture. The distal vessel is small.
Yeah. Okay. Coming out now.
Got good flow and hemodynamics and excellent.
Yeah. The question comes is, I think in this particular case, we should stabilize this mid lesion first with the stent.
Let's take a picture.
Yeah.
If,
and then
the flow is good.
Go to the distal. Yeah.
Now, opened up.
Yeah.
Opened up very nicely.
But which one you want to handle now?
Yeah, but the posterolateral is the bigger vessel, gets the collateral, and then there is a PDA, both of them. But posterolateral is a big. Our plan is stabilize the mid, then we bring our Godzilla 7 French and deliver 1.5 bar distally. So that is the plan. That was the plan originally suggested. Yeah. You remember, it's still very calcific, those OM branch, the posterolateral branches.
4 or 15? This is a 4 vessel.
The distal
Balloon.
PLV is very, very tortuous angle.
Yeah.
So I think that's going to be
What
a
is
little struggle. But I think that's a great plan because you'll
The
never
3,
get
5,
down there unless you fix this area.
Yeah. So our goal was that if we just to show the demonstration, yeah. You want to just do on the rotavar? No. Put
Why not?
side by side. No, will not.
It's not going to
Yeah.
go, right?
Yeah. Go.
So now we are going to go side by side with our workhorse wire, which is a run through. Dilate the mid area. Then you want to go with the
We use the
Godzilla
Xience.
after
We use
that.
the Xience. Yeah. Yeah. Put a 4 18 or 23.
What?
Xience. We use
We're
Xience
not
in
going
the.
to stent now. Stent later.
No, stand now. Why not?
I will not do that.
There's no reason not to stand. Just stand and stabilize that area, very big, and will help us
No,
in
I
every
see.
way.
So you're
You're
not
going to go with Godzilla and all that things. No.
The only problem is that I'll tell you, if you stent it and you are trying to manipulate the Godzilla through there,
Exactly.
you'll deform it.
Deform and
I
something.
would do a
no
bigger
need.
balloon.
Just balloon.
Leave
Balloon and
leave the rotor
stabilize
in
it.
there.
Yeah.
Leave the rotor
Balloon.
wire in there. If you want as a cutting balloon, a poor man's cutting balloon, plastic, and then bigger balloon, and then take your stuff down there.
Yeah, that's another approach, that just do the balloon. So worry about the Godzilla and all these extension catheters may destroy or may cause longitudinal stent deformity.
Not even know how it will behave. So just balloon it.
No, you don't think there is any need for any
Good.
cutting balloon there in the mid portion? Just a
Even
balloon
if
should
it
do it.
needs, you don't need. I think we don't need.
Yeah,
So
it
that
dilated
behaved
very
well.
easily. Yeah.
Yeah, 20 atmosphere.
Okay, good.
Yeah,
Done.
great expansion.
Yeah,
Okay,
we got
now
a modified one blade
Godzilla.
cutting balloon.
Other
We got a
side
one
was-
blade cutting balloon with that rota wire.
What was the
So
stent on
instead
the
of
left
4
side?
blades, 1 blade. Good.
Absolutely. Use whatever you can.
Yeah. Do it here. One little proximal edge.
For what? No.
No, just go a little further. Proximal part of the region. Just yeah, here. No, pull back a little bit.
Your balloon
angle,
is
yeah,
big
yeah.
balloon and it goes beautifully.
4-0.
I think you have to go. Yeah.
Yeah, the nice
Open
channel
the
has been
Godzilla now.
created.
7 French. Okay. Done. Only thing I wanted to do was that should have gone with the Godzilla. So with the balloon, we could have sucked it in. One step less.
Yeah,
but
plus
having 2
also
wires
when it
is
happens,
tough.
you take a balloon, you have 2 wires in.
It's okay.
And one
It's okay. 7 French will take
Yeah,
it.
but I know, but just get too
traps another wire, then your Godzilla actually comes around very nicely. We use some techniques sometimes with 2 wires and then use a balloon and it traps the other wire and then the Godzilla can go any part of the artery.
Good. So far, so good. Good.
Looking very good.
Beautiful.
Yeah. So we go to
Beautiful.
epicranial now. Yeah. Okay. So we go. Now question is where we want to know. We want to go to, but rota wire will not make that turn.
Yeah. No. Give me the Godzilla.
Yeah. On this.
Both. And then we'll go with the fine cross and then change the rotor wire to the. You want to change with the fielder fine cross.
Yeah.
Take this out.
Yeah, very diffuse disease in that posterolateral and a very large branch.
Yep.
Jaswinder, how I was reading about your program, pretty extensive endovascular reach, also structural too?
Yes. We had
Fine
all
cross.
coronary, structural, and peripheral, all three of
Just
those.
give a balloon. This one I'll
Actually,
go.
PK,
Get the balloon
Dr.
back.
Krishnan did an amazing peripheral session for us.
3.54 anyone. 3.5 is okay.
They run, and Dr. Matthews, they run our peripheral
No, we are
section
3.5.
with the help of Dr. Walker. So that was actually great. And then obviously our coronary session, Dr. Sharma and Anu. And we had live cases from France and
No.
from
What happened to the
so
other
we
balloon?
had
4
9 or 10 live cases.
don't use
So
this.
pretty
The 4 balloon.
extensive meeting.
What is
That was close,
Jaswinder?
and then
Put it back.
Yeah, go ahead, please.
go ahead, Samir.
So what
I
is?
said we had a
Please continue, Jaswinder.
we had a half-day electrophysiology section and a half-day fellows course, and then we transitioned Thursday, Friday, Saturday into our regular coronary structural and peripheral sessions.
So what was the message you got after doing this program with partial live attendance? You think people are ready to start going to meetings?
Oh my goodness, people are ready to start going to meetings. There is no replacement for human interaction. You can do virtual and Zoom every day, and everybody's zoomed out and everybody's, teamed out. I really think that the human interaction, the networking, and just seeing people is very, very important. And in our field is more important than anything else. So I think people are ready. I just think we need to be careful. I mean, obviously, we had health screening, we had all this checking every day and all the things that are recommended. So in the hotel helped us quite a bit. So we just have to be smart about it. But I think we are ready to roll here. I think you guys meeting in New York will be, I think Dr. Isaac said this for us in Scottsdale. So I think his approach, and plus hybrid, I think virtual is here to stay. We reach global. We never used to do that. So we learned a lot from this. So most meetings are now going to be virtual and hybrid, even though if all the restrictions are lifted.
We used to do YouTube.
Absolutely. Right? Let's, once we get more and more population vaccinated and the comfort and the safety of air travel resumes, I think that would be the major difference.
We have the wire.
Remember during our June symposium for years ago, we started YouTube live.
Right.
So people were watching from me. I mean, although the so-called virtual became very, big after this COVID, but before that, our June symposium was free, available on YouTube. Yep. All the symposia, even the top 10 October one, everything people could have watched from wherever they were.
Yep, we did that. Yeah, good. Okay, so now you see it here. We have brought the 7 French Godzilla down, and this is the fine cross going in and trying to get into. My question is, you want to decide, do you want just the PDA or want AV continuation? Should we take a picture or you try AV continuation?
Now I would not take a picture. Though now you see here, once you have your Godzilla down, always keep checking for your pressure. So here, if you see the pressure looks good, so we can inject. But if you see there's a damped pressure, do not inject when you have your Godzilla. I mean, that's a larger vessel.
Much larger vessel. I mean, and that's the one I think which is supplying the collaterals too.
I mean, that's what our thing is. Since there's a collateral already, do we just forget about it and just go to this PDA?
Okay, let's take a picture now.
Wire goes easily, you probably should. It's a very large vessel.
Okay.
No, slow picture, that's no problem. Slow picture is fine. And I'm going to magnify a little bit. Yeah, go.
No need.
The fine cross is having problems going down that PLV too. I think it's going to be an issue.
So, well, we have not tried yet. Let's try now.
Not with this wire.
Yeah, we'll take the floppies later, but let's do we have our fielder wire from before. Let's say.
You want to see a complex case? This is a complex case, but the steps are amazing. Every step there is a change of plan. Every step, you recognize what you're getting into, and Anu and that changing plan. So very, very educational.
Well done. Give us a new one.
It's all excellent observations, Jaswinder. Absolutely right, and it's been very gratifying getting the feedback from. The amazing part this year has been we've started being watched in the sub-Saharan African region. I mean, that has been absolutely amazing. Did not ever estimate that the breadth and power of the internet is 179 countries now watching at different times. Of course, most of them archived cases, but absolutely incredible media of education.
The question is, do you want a whisper?
Yeah, my absolute favorite wire for any tortuosity, but I think this will make it. There seems to be.
I would actually go for the stiffer.
Which one do you want?
Either a fielder, a pilot 50, or a whisper will do the trick in here. That's what I agree with you, Samir. That's what I usually use also.
So this is the fielder, but we are the pilot. We should start carrying pilot 50 also. We
have 200.
We have only 200, yeah. Because then rest we can take care with the whisper. I think it's a good whisper case.
No.
Yeah.
I am talking other way around. We should be a miracle 3 to get into that.
Anu, I would have absolutely predicted that is what you were thinking.
You can try the pilot, your pilot, because
pilot. But 200.
You can 200.
Why don't you try whisper once? Otherwise, we get a pilot. Yeah. Otherwise, get a pilot. Yeah. Let's try whisper.
Where are you now?
Yeah,
we are in the distal RCA.
It seems to be headed.
I think the guideliner, see the guideliner is not allowing this.
Yeah, it's probably working against you there.
Yeah. Okay.
There you go.
Good.
So what happened is I pulled the fine cross back.
Right.
Now you're golden. There
now we are talking.
Beautiful.
Yeah.
Okay. Yeah, I mean that's such a large vessel not to fix those lesions there. I think.
Good. Now let's see our.
But the PLV runoff is a big vessel, so I agree.
Yeah.
I think let's see if
the same we'll go with the floppy in this particular case. The RT likes the floppy. Good. And we take a 1.25 or 1.5.
1.25. Be happy if we
get a
can
1.25 bar. Yeah.
Right.
Yeah.
Yeah. I think Anu is right. That the bias in the angle of the PLV and it's not as big of a vessel. I think 125 here. And also going through the tortuosity of the mid, you're going to have issues with a 1.5 burr or anything big. So I think going 1.25 through the guidezilla, through the mid tortuosity and the distal tortuosity, I think is a very smart move.
Give us a 2.530 balloon.
Jaswinder, how big fellowship program do you have?
We have about 10 regular fellows every year. We have 3 intervention fellows. We have 4 EP fellows, 10. And we have 2 heart failure fellows. So it's a big program and imaging fellowship.
10 1 year or 3 years?
Program. Excellent. And moving to wrist access more and more?
Yes.
All right. So now we have a...
Yeah, I think our people are doing, we actually do. I mean, I still do, 80%, 75% of my cases leg. And I'll tell you.
Do you understand what a valuable training resource that is? People have forgotten how to even get femoral access.
Yeah, and we do ultrasound in all our cases. We do micropuncture in all our cases. And 85% of our cases, even complex left mains and stuff like that, they go home the same day. So I think learning the right way, because all this data that came out femoral and radial, they're old data. They're not new data. So I think we need to get better femoral also. And we do better femoral, I think we are okay.
Absolutely.
Just been there. You have been my friend, but you definitely are the best now. Because I am a believer of highway. I always say when you can fly in the highway, why you are going in this parkway at the stop signs?
Balloon is
doing
ready.
radial.
Yeah, good.
Absolutely.
So and as you know that I say that I show in my top 10 advances of 2019. I have Safari, Safari STEMI is one of them. And just to say that until I would say that 2019, every senior interventionalist who were doing predominantly femoral like you and me, 80+% were feeling bad. We were thinking ourselves that we are not worth it. But now we can say that's okay. It doesn't have to be every case being a radial. Femoral is good enough if you are good at the femoral.
So, Samin, just as we were talking about it here, Jaswinder, I'll let you answer that. The question was asked, why did we not do this case transradial?
We will be doing this case entire day.
Yep.
Right. Oh.
First of all, he'll never get in because he's got multiple fistulas and he's a dialysis patient, so that'll probably take those things away. But even if it wasn't the case, you can use this, they have these Asahi U catheters. They also came AL75. They're sheetless guides. I do decent amount of those. sheathless guides, it would have probably walked in here. The problem is, if it comes out, see, they have long sheet. If it comes out, then it's harder to manipulate to get in there. In this case, you need every purchase. I would probably, can you do it radial? Absolutely. I would probably not have tried it.
Yeah, agreed.
Look, it's the expertise to have
Ready?
both
Go
and
with
the
the-
wisdom
Let's see as
to
far as
choose.
possible.
Yeah.
Plus, the other thing people forget is when you come radial and you have any of these
Now we
non-numerous
lost it. It's even that one momentum, we have to keep going.
you actually lose the revolution
manually on
when you do
dynamic line.
atherectomy.
Okay.
So you have to be very careful, especially when you're doing this. When you're coming through so many tortuosities, you lose RPMs, you can stall. So you have to be very careful looking at all the tortuosities, all the biases and everything like that if you are doing high complex rotational atherectomy in there. Absolutely. If it's a straight shot, no problem.
Okay.
Okay,
we are
now
ready.
going back here, you see that? I think manually we were able to come up to the mid RCA, remember where the lesion was. And then after that, I could not advance, we could not advance manually. So we stopped there and then we got the burr through the acute angle to the distal RCA on the dyna. So if you see here, of our 9 centimeter, we still have 8 centimeters. So 80 millimeter of the burr we have, so we should be able to reach. So this was the point that we wanted to show when you have to go to the distal RCA, especially either you're talking RPDA or the lesion that we are talking, AV continuation to RPL, this is the way you need to do. I mean, in this case, we used Godzilla many times. You can use Dyna and go all the way if the vessel is not as tortuous as this is. That essentially, with Dyna, means you put the Dyna button on and manually you go forward so you do not lose your rotational atherectomy length, which is here.
And that is what we did. At that time, when you are activated, you have to press the brake release and then advance. Okay. Now let's see. We still have a lot of work to do here.
It's very similar to the glide assist that,
exactly.
CSI thinks
They actually had a very good system.
Yes.
Yeah.
Very good. Made
The first
made
band.
the curve very nice. Yeah, very nice.
Yeah, first one.
No, we still didn't make it. See?
Yeah, but we'll go. We'll come.
That
Do
distal
the polish
curve is,
problem. Yeah.
that
Just
distal
the
curve is very
approach
sharp.
of
Fine.
1 to 5 is just the right way to go.
Yep.
And
What we're going to do is we'll advance the knob tight and go forward with the Dyna glide, little more forward because we don't have that purchase left. Go.
Now, other thing is the ceiling camera, guys. Can you focus
me.
more?
Yes, yes.
No, focus more.
Yeah.
Can they come further? No, not that way.
here we go. Here.
Come in.
Yeah, we watch it very nicely.
Okay,
Go.
good.
Yeah. Yeah. See? So Dyna glide, it's a tight. You
Okay,
make
good,
sure.
good.
Yeah,
Wire
good.
is coming back.
Enough. That's okay. That's all we need. So we got that purchase, that another 40 millimeter. That should be good enough. And then you have to advance the wire, brake release again. See that
Okay.
brake release and then advance the wire. Show my hand. Brake
Very
release
good.
and advance the wire. Yeah.
Made the second
Yeah.
curve also.
Bend. Yeah.
Yeah, I think you are good now.
Yeah.
I would take
Good.
it out. You're
Yep.
good.
Good.
You're
Come
good.
out.
Good. Yep.
Hemodynamics are all right.
Yeah. I mean, same thing. Try to finish it
Exchange and
quickly
run
and
through.
come out. Like Jaswinder was mentioning, no need to cause
You want
unnecessary ischemia.
Yep. Feel the fine cross or we just.
You just give
Side
me
by
regular
side.
wire, side by side.
Yep.
Oh,
No, this is a
yeah.
Godzilla. No, I would
Godzilla.
go field get a fine cross again and exchange them
Yeah.
through.
Run through.
Run through.
Yeah,
So
I
we'll
would-
go with the fine
because of
cross on the
that-
rota wire.
Yeah, because of that bias and stuff, I would take
Yeah.
a quick.
Exactly. Over the wire. Yep. Absolutely.
No, that's one. And the other thing is, Godzilla, when you're wiring side by side, at the entry site, the tip of the wire can get
Good.
mangled.
Yeah, but that's a good point. You could actually put the fine cross first. And
Yeah,
then the
that's what
fine
we are
cross
doing.
hole,
Yep.
and then you do the stuff. Absolutely.
Right.
Absolutely. Right.
Yeah, usually we go with the side by side wire, but in this case, for various reasons has been mentioned, we just I would say appropriate to exchange it.
So, I mean, it's a
We are
question
not taking a
which,
picture yet.
question which
Take a
came
picture.
earlier,
No.
which I think has been already answered.
You want?
Yet I
Okay.
will read it out for the sake of completing it. Did the thought of using any imaging enter into our consideration?
Question is to see what? I guess my question is that you need to do imaging, but don't be just imaging fanatic because you have to do imaging for what? So in this particular case, I don't think there is any question about calcium. There isn't anything about the vessel size. So I think it's a reasonable in the end that you may do the imaging to optimize your outcome, because here there is no question about the tortuosity. There's no question about calcification. So all those things are taken, together. So therefore, imaging at this minute is not going to help the interventional, taking out any of the interventional decision. So I can see, like, moderate many of the live cases, there is a bad dissection. That everything is going on, and they still want to see with the imaging dissection. I said, what do you think it is? Is it a foreign body or what? I mean, it's a dissection. Yeah,
I know.
Fix it
But
first.
here, no, you're right. Plus, imaging would not go in the beginning. I can guarantee.
Of course.
So
No,
I would do all
that
these things they're doing,
yeah.
and then
Anu, back with the run through.
This is back with the run through, and see, when the early part, remember, we had the abnormal flow. So in that situation, if you start putting extra catheter, there's a risk of closing the acute closure of the vessel.
Or
Once there's I mean, if you're trying
and
to
promoting the slow flow further even,
further, and then your chance of doing a atherectomy goes down. So that's why I think if you want to do imaging later part, like I mentioned, I think angiographically, train your eyes to do PCI angiographically, especially when it is very complex. At the end, if you want to make sure that your stent optimization has happened,
have they done the
especially if you're doing left main, then imaging is a must.
Yeah.
Jaswinder, Barnes Jewish Hospital, all heparin or some bivalirudin still?
Pretty much no bivalirudin, unless your platelets are problem and all those kind of things. But otherwise, every case is heparin for now.
Cangrelor?
Cangrelor, some patients, yes, some ACS patients, but in general, Cangrelor has a good
What
use.
stent you want?
In general, heparin, then preloading, and I think we are good to go.
Go.
Very good.
Up to the ostium?
Yeah.
Ostium, no,
PDA.
then we will lose the PDA.
No, but PDA you have to open end also.
You see, this kind of cases, I mean, that distal area,
33.
we had perforation.
No, this is 30,
If you didn't
no.
do 125 and you didn't do it the right way that Anu demonstrated. So this is as complex as a rotational atherectomy case gets. But I think to minimize complications, I think, we got to learn these techniques. We really got to learn this. So this is an illustration. This is not one-on-one rotational atherectomy. This is advanced uses rotational atherectomy. So very, very important steps.
Right at the beginning of the case, I observed it's an excellent teaching case. Every aspect, the proper use of guide extension catheters, the sizing of the burrs, eliminating of the wire bias, and it looks very good. And just like how Samin and Anu observed, the PDA is probably will need to be wired. Yeah.
Now we are, taking pictures. Again, I'm making the point. If you see the blood pressure, since the vessel is large, despite having the guide extension in the distal RCA, there's no damping of the pressure. Two things, you have to be very cautious when you have the guide extension all the way distally. One, dampening, and when you're injecting, cause dissection. Two, if you're doing, prolonged PCI, then there's a risk of thrombus formation also in the guide extension catheter. So once you have guide extension, I always tell fellows also is then you need to have your photographic memory of the vessel and keep doing the PCI fast.
Side by side. Okay, so goal is we are going to wire our side branch, which is the PDA, and just do the balloon. So that will be our keep artery open. We have a 20.
2025.
25 compliant. Give us the compliant balloon. Yeah, 12 or 15.
Just the area of myocardium supplied by the
this got destroyed.
The distal branch where you are is extensive.
Yep. You need a wire balloon support.
Wire got mangled up a little bit.
Yeah, that's the same at the when you enter
easily.
the.
You may need a
Okay, you're
little
in the
wire balloon
PDA.
support. We have the balloon support.
Going into a small
I know,
branch
because
of
you
the
need a balloon
PDA.
support, yeah.
Can you give some dye so I know if I might have entered another branch?
No, you're in the PDA.
Okay,
You just have
good.
to make a
Looks the right
lower
place,
turn. Yeah.
just
You had it. You had it. Yeah.
It's going to a small branch there. Okay, good.
Yeah.
Got it.
Yeah, even there you can leave it. That's okay. We don't get crazy. We have to open the ostium only.
Jaswinder,
Yeah,
we
the
have
vessel is not that big.
extensive business intelligence tools about where our
Okay, you want to
audience
take a
comes
38
from,
then?
and
Yeah.
to our
2538.
very large followers of the program
then 40
CCC live cases
mid.
in India.
Yeah.
Our best wishes with this terrible COVID crisis which is happening there, and it's just very scary. I mean, whether we call it the second or the third wave, it's frightening, the extent
Good.
of the raging
2538.
COVID.
Yeah, and particularly as you know that United States being the highest with a 26% viewership, and India is the second with 18% of our 10-12,000 per month.
Good.
That has been clearly, I feel bad. Although today, first time in last 8 days, the curve has gone down. Yesterday was 282,
Down.
today 264. Otherwise, it has been increasing. Yeah.
Samin, immediate result of the lockdown, I think, and you know, it's. I think it could have even been done a couple of days earlier, but just reckless behavior with all the
we're going to stand
all the
across here.
religious festivals and the election rallies and the cricket matches. It's just, I mean, teaches so much to the rest of the world that you know, vaccination is just the beginning. This is a very long journey.
Absolutely. Take one more picture.
Absolutely.
No.
Absolutely.
You put the
I'd
stand
like
now.
to echo
Yes.
those and wish everybody the best, and please, you know, stay safe. I mean, it's not like we are doing hybrid and in-person things now.
If you want to
Because
OC,
we
you can make the OC.
No.
didn't do anything. We had lockdowns. We had
No,
all these
I
things.
Well,
Just be
I will see the
patient.
proximal.
You're going to get there. I
will.
think this is the time not to be venturing out and going crazy.
Absolutely, just too unsafe to take the foot off the pedal of the safety. I mean, this is, you know, in many ways, I think one of the wisest approach which has been recommended, at least in the US, is that let not the vaccination, the fact that we've been vaccinated, camouflage the fact we are still exposed. I mean, this is the virus still, the number of variants, you know, in India. Okay, so we have the PDA back there very nicely.
Yep. Go. And we are going with the 2.5. Yeah, that's okay. Go. 2.5 38.
Slow.
Outstanding
Don't make
teaching
noise.
case, really.
Yep. Go. And key is that the people ask 6 French guideliner Godzilla will not take even 1.25 bar. May take the orbital atherectomy bar, but definitely not.
So that itself, Samin, is, I mean, although one can push all of that through, but with the
I'll pull
radial,
back a
that is
little
all
bit.
going to be extremely challenging.
Pull back a little bit. That's okay. Just
Yeah.
one-
Also,
one-
you have 2 wires in place. A 6 French,
good.
you will not, the stent
Right.
will not go, and
Okay.
you'll strip the stent. So you have to be very careful, especially 7 here is the way to go. You can see with 2 wires, with the
This
7
one we
French,
need
you
to
can
post, right?
stent, no problem at
Get
all.
us a 358 high pressure.
Samin, I'm sorry, what do you have there at the moment?
This is a 25
Long,
38. Yeah.
38 Xience.
Xience.
Yeah, go little distal massage. Yeah. So 2.5 38. So what we'll do is, I want to see, no, why didn't you go distal massage with this? See if you can go a little bit. Can it go? No. Yeah, a little bit distal. Yeah, good. Just 1 second. Yeah. So you know what I do in a long lesion, just 2 atmosphere. Because distal massage in the sense that it is very likely you advance the vertical displacement of the plaque. Just 2 atmosphere. No, not causing any injury. See there, 2 atmosphere for few seconds. Now we can come back, take the picture. So what our goal will be, dilate this proximal part of the stent with the 3.5 and then
8.
3.58. And
And then we
do
put
the
a stent in the mid. That's a.
and then stent in the mid.
All right.
Three,
And
five,
then,
eight.
they're getting ready for the OCT. Yes.
Let's
Well, as
take
we
a
mentioned.
picture and verify those plans.
Yep.
Validate them.
Okay. Now, do you want to remove Gargilla now? Bring back into the.
No.
Oh, you
No,
want to
just use
dilate
it.
that way?
Just
She
use
wants
it.
to. She wants to
Just
see
use
the
it.
picture first. Yeah.
Okay.
No, not that way. He wants me to remove the for the post dilation. I'm not
Right.
going to change this current atmosphere there. The current atmosphere is working very well.
Very good. Good. Okay. So
Absolutely.
while we are trying to do this dilatation, look at the beautiful PDA is open, posterolateral. Our goal was such a complex have been done. While we can put on one side, we can go to the slide presentation. So we go over 2 points.
No, I have one other point.
Yeah.
So I'm going to pose, since we brought the stent into the distal RCA, which is almost 4-5 vessel, it's a 2-5 stent in the AV and RPL. We are just going to open the ostium with a 3-5 high pressure balloon. Now, when we are doing that, we have jailed the, the wire in the PDA. So, you can leave it there, or if you want to remove it, you can remove it. It's up to what you feel comfortable. I'm going to leave it and post dilate it.
It's a short area of stent proximally in the distal right. So I think you're okay leaving it. Your angioplasty it is in case there's a tear, it may shut down. So I would just leave it there.
Good.
And there's some data that you can even leave a balloon in the side branch.
Sir.
If you're that much CI, for the bifurcations, that just leave a deflated balloon. And if you decrease the flow, just inflate the balloon, take it out, and then of course you do a kissing. Okay, I'm doing it here now. That was 10 atmosphere because it's a 3.5 balloon.
Okay, done.
And now it's a 14, 16, 18. Okay.
Get us a 4, you want the whole thing
23.
18?
Yeah, 23. Angle.
No.
Nice angle will be 18 or 23. I would say better will be to take a 23 so to make the whole angle. And that time you can remove your, 23 will be 4 or 23, Yep. Okay,
Now I will remove the filter wire that's in the PDA, and then we'll go with the 4 in the mid RCA. After that, we will do imaging of the mid RCA. Yeah.
So, I mean, no intention at all to going after the PDA, no? Just leave it.
But no PDA, we open with a balloon, yeah?
Yeah.
Okay.
No, it
But
means to give
no
tension.
stent.
No stent.
No stenting, yeah. No stent.
Got
Yeah.
it.
Let's take a picture.
Adequate flow there.
These are the kind of thing you have such long stents. Just make it simple.
Look at the PDA open.
No,
Remained
good flow.
open.
Yeah.
Yes.
Nice flow there.
Beautiful.
Okay. So while they are putting a stent, we can go to our presentation, please. Keeping in time also. So we basically the 2 points I want to talk about, and that is lot income in the literature now about colchicine, such a cheap old drug coming back, taking a resurgence into the coronary artery disease. And second is we always have one focused review of the month, and this is the impact of hemoglobin A1C levels on cardiovascular outcome post PCI, which is reported from Mount Sinai Interventional Registry. So first is our colchicine. What is colchicine? Colchicine is one of those anti-inflammatory. Remember, we have worked on various agents, particularly the lipid, and so now we are going through the inflammation. And you know that many of the studies have been done with canicum, tocilizumab, all these very complex names can't even pronounce. But whole purpose is make beyond just statin other anti-inflammatory therapy. There actually just came another paper in the JACC about the IL-6 antibody this week, but we know the CANTOS trial and show have been using, they've used other agents, but the key is this colchicine works at the level of IL-1B and prevent progression into IL-6. This is the inflammasome, and this actually has been very nicely showed multiple mechanism of colchicine working in various pathway of this inflammatory cascade. And this is all the black and white diagram, but also adds to it that besides just the inflammation, it also works with the neutrophil and platelet interaction and cause the stability of the plaque. So key is all those factors are affected with the with the colchicine. So this is the background of the colchicine, besides using for the gout, that for the coronary artery disease. So now based on this, first study was done from Canada back in 2013. Nobody knew at that time. A small study called LODOCO, and basically low dose colchicine and about 500 patients, colchicine 0.5 milligram per day versus control group, and found a remarkable advantage in reducing the primary outcome of the death, MI, revascularization, all in a colchicine group. These are the individual endpoints. So overall, it seems to be that colchicine made the way into the coronary artery disease. And this was a very nice editorial to show cooling off hot hearts, a specific therapy for vulnerable plaque. This was predicted 8-9 years ago with this small study. And you see where we are now. The latest data was from Canada and Netherlands combined with a colchicine patient with CAD, which is LODO-CO2. The same authors, now large number of patients, about 5,500. Stable CAD, these are not unstable. Stable CAD, all are on statin, all on guideline and directed medical therapy, and randomized to 0.5 milligram colchicine per day. And for 1 year, and look at the endpoints, significantly lower in the colchicine group of the death, MI, stroke, and revascularization. Only thing was that in this a slight increase in death. You can see 2.6 versus 2.2, and that message will continue further on. But overall, reduced MI, reduced revascularization, and other endpoints, no difference in death, maybe slightly higher. And other side effects which are shown here, people always worried about the gastrointestinal symptoms, the pneumonia, the infection, because felt that any anti-inflammatory drug that actually have been with other agents also, anti-inflammatory may cause more infection. So this one actually seems to be little but not prohibitive. And so therefore it seems to be that colchicine coronary artery disease has a role with a 0.5 milligram per day. Now, and we know that the trial 2 years ago with the COCAT, the patient with the STEMI COCAT trial, another like 5,500 after in the STEMI patients on day 3 were started on colchicine 0.5 milligram daily, continues for 1 year, and again showed the same message. Benefit in the colchicine group, as you can see here, and of course the death again was no change in this particular study, but all MI, stroke, everything else was lower in the COCAT trial. So it seems to be that colchicine has come in. Now anytime you do multiple trials, one trial was, this is the Australian COPS trial, again patient with acute coronary syndrome, about say 800 patients, and basically in this trial first time they gave 0.5 milligram twice daily for 1 month, and then 0.1 milligram daily for 11 months. So until now, that all the trials use 0.5 milligram daily. In the COPS trial, they use twice a day in 1 month and then once a day. Now also I want to say, disclaimer, remember colchicine at present is available only 0.6 milligram. It's not FDA approved because 0.5 is only for the trial. Clinically, availability is 0.6 milligram of colchicine, and basically showed no difference in no difference. And see the death, actually there was a higher death rate, but and of course lower acute coronary syndrome, lower revascularization. So their conclusion was that addition of colchicine to standard medical therapy did not significantly affect cardiovascular outcome at 12 months in patients with ACS, and was associated with a higher rate of mortality, and those were the non-cardiac mortality. And I'll come back to that point. So these are now the 5 randomized trials which have been now enumerated here in the various patient subgroup. But overall, it seems to be the patients with the diabetes, patients with MI, patients with the CAD, colchicine consistently. And this, you see that everybody getting double antiplatelet therapy, statins, beta blocker, and overall showing that the primary endpoint of MACE or revascularization is lower in the colchicine group and stroke compared to the placebo group in this randomized trial. The only issue comes down is the patient with a death. So death, basically particularly non-cardiovascular death. You see the odd ratio, 1.38 in favor of no colchicine. So clearly somehow some non-cardiovascular death is a little higher. There is some trend, maybe a cancer, but overall studies have shown no difference, which is here, infection, pneumonia, GI, cancer, unity. So basically it seems to be that colchicine is here to stay, and we should be adopting 0.5 milligram or 0.6 milligram. This actually put it together nice, the central figure, this European Heart Journal with a meta-analysis, and showing in the bottom the mechanism that it works on activation, decreasing IL-1B. Then other is the neutrophil chemotaxis, adhesion and activation. And thirdly, inhibiting neutrophil platelet interaction. Decrease MI, decrease stroke, decrease revascularization, although not with the cardiovascular death. And I can tell you, this is basically time to come or take out the colchicine. I started using colchicine for last few months, and I can tell you clinically, I'm very happy with this. Rather than ranolazine, to me, colchicine is working very, very well. And there are many randomized trials in the pipeline, which we'll hear more about in various setup, whether it's a post-cabbage, post-intervention, post-medical therapy, and so on and so forth. So second point I wanted to quickly talk about is the focus review is the impact of hemoglobin A1C. This is what we did is from our interventional large single center registry database of patients, we measure A1C in every patient, and we followed the patient through 12 to 14 months and see what are the cardiovascular outcomes. And basically this is the 13,500 plus patients, and you see the one A1C level. We have the other follow-up levels also, but the primary point, start point was what was the A1C level at the time of PCI. And you see here 5.5 in 1,200 patients, 2,200 between 5.6 to 6, and 6.1 to 7 in 4,000. Between 7 and 8 and more than 8 was in 3,300. So basically these are the some characteristic differences. Patients with a high those who have a higher A1C, they're more sick, more medical conditions, and their stent length and all those things are also adverse. But what we found is very interesting. As you can see here, death. Once you go to the 5.5 and below, there is a higher death rate, which goes down when your A1C goes up. Look at the MI, has a totally inverse relationship. Higher the A1C, higher is the myocardial infarction, and there is a trend towards higher target vessel revascularization with a higher A1C. These are the various figures, and this is very nice diagram to show the U-shaped curve. U-shaped curve, one is the A1C distribution. More importantly, that in the lower, you have high event rate when it is less than 6. And that is because of death rate. Then you have higher event rate when it is more than 7. That is because of higher myocardial infarction. Very excellent analysis which we learned by doing it, and this is actually put it together of various points of death, MI and TVR, and shown here. So this basically this among patients undergoing PCI, pre-procedural A1C level display U-shaped association with 1-year MACE risk, a pattern that reflects great risk for death in presence of A1C less than 5.5 and higher risk for MI when it is more than 8. So this is what we learned from our study. And though, of course, say glucose control in patients undergoing PCI, probably we should not be too strict. Keep it between 6 and 7. That is what we learned. If I sum it up before I go to the questions, what we learned is colchicine reduces cardiac events. Colchicine reduces MI in CAD patients. Colchicine reduces non-cardiac death in CAD patients. Nope. It rather increase some non-cardiac death, and colchicine serious side effects does occur, but not that common. And lastly, the A1C, I think it's a new level. Don't go too harsh. Don't bring it less than 5.5. Don't go more than 8. So 6 to 7 is kind of a sweet spot. And I know that Anu is ready now to do the OCT.
So, I mean, both publication of great relevance. A quick question for you. When you said you have been using colchicine and have been encouraged, you've been using it at 0.6 milligram daily?
Yeah, 0.6, yes.
And for what cases have you been using them?
Refractory angina. Patients have you, looks like you did a stent, 1-2 months later, they come back, vessels, we know that it was one vessel only, no EKG changes, but symptomatic. We used to give this one only side diarrhea and the GI are common. Improvement.
Okay, we are ready for OCT now.
Okay.
Yeah, very novel agent, lots of very convincing data, still a little disturbing as to even the non-cardiovascular increase in the mortality, I think will probably need to be explored a little more. Anu, a question for you. There is Dr. Kapil Bhargav from India has asked specifically about really the need of using Dynaglide when you are advancing. I think you've kind of answered, but I think it's a relevant thing, so you might as well explain again.
Yeah. So Diane, I think I have spoken to this company people last week, which because I get several questions via email and WhatsApp, exactly the same step. Because remember now, other than making the apps, what I'm trying to do is making animation so people will understand. No matter how I try to teach the steps, is making probably an animation and explaining how the three things interact with each other. So when we are doing rotational atherectomy, we are dealing, other than the guide, we have the rotawire, then we have the rotaburr, and we have the Teflon sheath. So essentially we have three things here. This is the device, and you have the rotawire, which is here. You want to put the rotawire quickly? Okay, rotawire. So then you have three things: rotawire, you have the rotaburr. Are they showing? Can you go full screen?
Yeah, go to full screen on that.
Yeah.
No, good.
Yeah, good. So you have the rotawire that is here.
Yep.
Then you have the Teflon sheath and the rotaburr. So your interaction is between the three things here. So when you have the rotawire in the vessel, you see we place a clip. So the clip, what essentially it does, it prevents the wire from rotating when the burr is rotating, so the tip will remain stable and not move backward forward. Also, to do that, to keep the wire in place, there is a brake here. So this button is a brake that will hold the wire in place. So when you have that wire in place, then the Teflon sheet and the rotaburr moves on top of it. To do Dynaglide, if you have the brake on, this is not going to move on that. So you got to do brake release. So essentially, the three things, which is the wire, the burr, and the Teflon sheet, they are free. And then on the Dyna, what's the meaning of Dyna is the rotation happens with the slow speed of 65 to 70,000 RPM. So even if it jumps, it jumps with a slower speed, so the risk of dissection and perforation is low. So what we do, you do brake release, so the so-called the wire is free, these two the rotaburr and the Teflon sheath is free, and then what happens is I will keep advancing slowly, manually I'll keep advancing. Start the Dyna.
Yeah. So and make sure the knob is tight.
Yeah.
That's another point. Yeah.
Keep going, press the Dyna. So I will keep advancing slowly, manually. Okay, manually will advance it.
Yeah.
So the goal of doing that is this length. This is 9 centimeter, 90 millimeter. You need this length so that you can perform your rotational atherectomy. So you see how we did the distal RCA. First time we were able to do the distal RCA to the AV continuation, but we could not make the turn into that RPL. To make that turn again, we had to move a little bit further of the Dynaglide and then get that length to go make the turn into the RPL. So I mean, I know this is required, but I think once you do a couple of times, you will get it. And I think that's a point which we wanted to make about the various devices that we have right now for calcium, which includes rotational atherectomy, the good old rotational atherectomy. Then we have the orbital atherectomy and new kid round the block, which is the IVL. I think all these masters of calcium should have what I say a written document, so everybody will know which device to be used in which situation. And rotational atherectomy, why people are running away thinking that it is difficult to use. No, I think we have the calcific app. There's so many live cases where we are teaching the steps. Moving forward, I think we will do some animation and teach all the steps. Like I said, Rota, which has been there, old, which Dr. Sharma always likes to say old is gold, but I think we can call it old is diamond because this has diamond chips at the tip. And if you learn that, how to perform rotational atherectomy like we showed, you'll be able to do any case the way we have shown today in a, I would say, complex case made simple.
Yeah. And just to add to it,
Samin, go ahead.
Yeah, one more note, just key, the many times you are having a trouble advancing your burr into the guide, from the guide to the vessel, whether RC or left main, same way, rather than push and pull, put the guide, no, just advance manually with the Dynaglide. So that will be less trauma. So, but the key, more important is how to advance. I know the question was asked earlier, last month or month before also to know, but now we have gone through step by step. Yes, Samir now.
I will give you the indications when you need this is same like I mentioned when you have anterior takeoff of the RCA, like here. And then you have Shepherd's group RCA, where it is not going to make the turn. Every time you go, it's going, guide comes out. Ostial RCA, distal RCA. Rarely you see the LED that has a takeoff that is also crooked, where you'll have to need dyna. And of course, circumflex. If you're going to do dominant circ, you're going distally to the LPDA or LPL, you need this technique to reach to the distal vessel.
Look, clearly a low speed mechanized motorized advancement. You illustrated it so beautifully, highly instructive. The OCT stent expansion is looking good.
Yeah.
Yes.
So if you see overall, no red sign, no stop sign. It's all
looks
right?
very good.
Yeah.
His key? Yes.
Yeah, well expanded, well upper.
So we post-dilated, we put placed a 4-0 stent, and then we post-dilated 4-5 at 22 atmospheres.
Yeah, and no edge dissection.
Good. And this is the last picture you see it on the left.
And the total will show you, total contrast was 180, fluoro time was 31 minutes, air karma of 1.8. Anything about 2, we need to record.
5.
Yeah, anything about 5, but we aim for less than 2. Yeah, and DAP of 164.
Yep. Okay, so let's just come back to the last, our 3 questions, and we wrap up this. Go back to the slides again, which we always have 3 questions at end related to what presentation has been made. That is, the following statements are true regarding the outcomes of colchicine versus placebo in the randomized clinical trial, except colchicine use associated with a lower MACE, lower MI, lower stroke, lower non-cardiac death, and lower revascularization. Clearly, we said there is a higher non-cardiac death. Second, following statements are true regarding the potential mechanism of action of colchicine causing improved cardiovascular outcome, except colchicine inhibits inflammasome, activates IL-1B, inhibits IL-1B, colchicine inhibits neutrophil chemotaxis, and inhibits neutrophil platelet interaction. Clearly, it does not activate, it inhibits IL-1B. And lastly, the statement true regarding the impact of A1C on cardiovascular outcome. Levels showed U-shaped curve in outcome. Levels showed higher MI with higher levels. Levels showed higher mortality with higher levels. Levels showed higher mortality with levels less than 5.5. And levels of 6 to 7 were associated with the best outcome, and answer is yes. The C is wrong because it is higher mortality with the lower levels. With that note, we conclude from our side the presentation of today, case number 142, and thank to our all CCC live viewers across the globe.
And Jaswinder.
And Jaswinder, yes.
Very efficient review. Jaswinder, let me chime in my gratitude. You complemented the excellent case with your very astute observations, and thank you so much for being here. We conclude here, and we'll see you on May 18th.
No, ask him to comment.
Yes, go ahead,
Yes.
Jaswinder. Very appropriate. Any final
Yeah.
comments and observations from you?
Yeah.
No, Samir, thank you for having me. Dr. Sharma, Dr. Keeney, all the team, you guys did an amazing job. You are instrumental in education globally, and we congratulate you for an amazing case. And thank you very much for having me, and we'll see you in live soon.
Okay. Perfect.
Wonderful. Thank you so much. We'll see you all on May the 18th.
Thank you.